Hello, 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 everyone. How are you? Yes, we are here. This is our last session. Are you ready? Go ahead, type in the chat. Let me know. Let me know how you're doing. Let me know if my mic sounds okay. Good morning, SKMA Donald. Hi, Star Wars girl. It's been a long time. Thank you so much, Britters. I see you changed your name. Thank you, thank you, thank you. Hi, Nicole. Welcome. Hi, Miss Dolly. Hi, Miss Mills. Yes, we're going to wait for a couple of more people to come in because today we are going to blitz. Indeed. Let me go ahead and remove this banner because we need the entire screen. And there's something new going on. This streaming platform now enables you to stream from two different ways. I don't know if it's this platform or YouTube. So if you're using your mobile device, there's um, one link you should choose. If you're using a desktop, choose the other. It just depends. One is horizontal, one is vertical, but I will tell you that the AMCI instructors are going to be in the vertical one. Yes, the traditional one. But if you're viewing and you need a good view, go ahead and hop on over to the other one. And you know what? You all are amazing. So the people that are filling out these surveys, thank you. Thank you, thank you. But I want to remind you that the survey is important. It helps me help you. This is where not only you can tell us how it went, it's only one or two questions. I don't think it's a lot, but there's an opportunity for you to tell us what you like. And you know what? I read them. Someone said, hey, every time they say PCS coding, PCS coding, I heard you. I heard you, and it's coming. It's coming in 2026. That is really important to me. All right. And we have something else that's coming, and I'm going to tell you about it at the end of this session. Okay, so our numbers are climbing now. Just want to let you know that this is the first ever AMCI E&M Blitz. If you know anything about football, you know what a blitz is. I'm from Blitzburg, Pennsylvania, grew up there. The Pittsburgh Steelers coined that term and we use it all the time. Now it's my opportunity to share it with you and show you a blitz. Yeah, in medical coding. All right, so an E&M blitz. I think somebody else is doing a blitz. I think so. All right, now let's just begin with our copyright. CPT is 2025 copyright. AMA. All rights are reserved. AMCI trademarks are Keyword Concept, FTR, Chun, AMCI Fab 7, AMCI ICD 10CM Flip Tap, and MCG. These are all our registered trademarks. And the credentials CPC, CRC, COC, CPMA, CPB, CPPM, CPCO are owned by AAPC. And the credentials CCA, CCS, CCSP, RHIA, RHIT are owned by AHIMA, and AMCI does not own the rights to these credentials. We prepare you for these credentials and we do it well. And today is going to be the proof that you are ready to code evaluation and management. So, welcome, welcome, welcome. I'm still getting my sound together. Everyone said it's okay. Welcome, Mr. Sandeep. Welcome, Vina. DK for Kitchen. Matthias. If I'm saying your name wrong, please and thank you. Also, I see somebody saying hi to Miss Rosa. How are you? I miss you. All right, look at that. Okay, did I miss anybody? No, let's go. And if you want me to acknowledge you, go ahead and type in the chat. Hi, Miss Lily Mae. I know you. All right, we've got a disclaimer. That means that if you are a novice coder, you might not be ready for this, but you will be. If you watch the playbacks, you're going to be somewhere around ready. Or if you're new to medical coding, just kind of sit back, relax, and enjoy your learning. All right, and don't forget, go ahead and like this video, like it right now on YouTube. It helps us. Every single like for every single video helps us. And don't gatekeep. Share, share. The more you share, the more we're going to make. All right. So previously, we took a deep dive into evaluation and management. We started out with evaluation and management guidelines. We went in and we discussed E&M level of services on a basic level. We didn't go really deep in it because a lot of you already knew that, and that was good. We talked about the different locations, right? Yeah. And these general coding guidelines and how they're always pertinent. And you're going to see that come play out. And we want you to remember one E&M code per practice, per patient, per condition, per day. That's important. You always have to remember that in the back of your head. And you also have to remember that there are some exceptions. So we have some charts for you and apply them, use them. But identifying the location of the visit, you know what, coders? I think that's more than 50%. That's more than 50% of your of getting it correct. And this is going to play out. It's going to play itself out. Make sure that you remember I said that. All right. So previously, we've shown you these multiple same day practice visit charts. And these charts kind of help you when you have multiple visits on the same day. Traditionally, this is how you rank it. You're going to rank critical care first, admit and discharge in the same day second, inpatient consults third, inpatient visits fourth, nursing facility visits fourth, ED visits fifth, and outpatient consultation sixth, outpatient office visits seven, home and rest residents will be 8. Now, discharge is not 9. I just put it there because I want you to know that that's pertinent. And actually, discharge is also an exception. It's an exclusion, and you can see it here. So, what are the exclusions? Just so you know, if you have any of these encounters, that means that they may be able to be coded in addition to another E&M code on the same day. Yes, not always, not all circumstances, but there's a probability and a possibility. Yes, prolonged services, critical care, preventative medicine, inpatient discharges, delivery and birthing and resuscitation, newborn services, pediatric neonatal critical care, case management services, care plan oversight, psychiatric collaborative care, care management, transitional care, advanced care planning, cognitive assessment and care plan, behavioral health integration, and others. These are the exclusions. Now, coders, today we're going to apply everything that we learned to practice, and we're going to feature the AMCI E&M Blitz, and we're going to, at the end, use the free evaluation and management tool by AAPC Codify. Now, why are we doing this? Because you will have access to this tool when you take your exam. Yes, if you're taking the CPC exam, you may use the tool. Now, let's review how to solve an E&M scenario for the medical coding exam. Number one, you're going to inventory. What are you going to inventory? You're going to inventory diagnoses and procedures, location of the visit, the provider type, the visit type, and if it's MDM or time. If it's MDM, you're going to score the PDR. If it's time, you will use time. And if it's both, you will use time for the exam. Okay? Step two, you're going to apply guidelines. Step three, you're going to go ahead and look up your code. Now, coders, are you ready for the E&M Blitz? Yeah. All right. So I don't know how many we're going to get done, but you know what, coders? I may go over. So if it's 12 o'clock noon, go ahead if you have to step away, but we're going to get this done. Are you all ready? All right. So these are some exam like scenario subjects. They may not be as the same size, and they may be, but those subjects and those guidelines are key. All right. Here's the first scenario. As you can see, your inventory, what you need to inventory is here, and the codes are here, so you don't have to look it up. All right. Of the following answers, which best describes the encounter? A, 99222, B, 99231, C, 99232, and D, 99223. Dr. Reed evaluates a patient admitted to the hospital yesterday for pneumonia. Today's encounter includes review of labs and medication adjustment. The total time spent is 28 minutes. Okay, coders, you can go ahead, start putting your answers in the chat, and yes, we will be moving fast. All right, someone said this is their first time here. Welcome, 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 Nashok. Hello. Hello, Barbara Ann. My aunt is Barbara Ann. Thank you, Miss Mills. I see you. All right. Go ahead, place your answers in the chat. What say you? Good job getting that answer in. Hello, Walaka. Oh, Wala Kamal. I hope I said it right. Hi, Jalicia. Shantae. Hello, hello, hello. Okay, I'm going to solve. And what am I going to do? I'm going to inventory. Inventorying that this is a hospital admission yesterday. The pneumonia is the diagnosis. Today, the doctor came in and visited this patient and reviewed labs and medication adjustment. And the doctor spent 28 minutes. So my thought process is if they're talking about yesterday, then this encounter is pertinent to today. We need to focus on today. So thought process is this a subsequent visit? And what is the MDM in time? So if the visit was yesterday, what are we doing today? Today, he reviewed labs, medication adjustment, etc. So yes, this is a subsequent visit. This and 28 minutes is documented. It's going to be based on time because the time is documented. So when you have the exam, you go off of the time. In the real world, your provider will tell you. And if you can show your provider that you know how to score, are you're an asset. All right. So my answers is yes, this is a subsequent visit and the time is 28 minutes. So I'm going to go into the subsequent hospital visit section and look at the codes. We have 99231. This code is for subsequent hospital visit. 25 minutes must be met or exceeded. Likely this is my code because if I look down at 99232, this is 35 minutes has to be met or exceeded. So this is wrong. So my answer is going to be 99231. And if you said B, way to go, way to go, way to go. You know what? You all knocked it out of the park. You did. You ready for another one? Let's go. And if you want to know the pace, this will be the pace. We're going to try. Okay? All right. Of the following answers, which best describes the encounter? A, 99202, B 99203, C 99204, and D 99213. A new patient visits the clinic for evaluation of type 2 diabetes and new onset of ankle swelling. The provider orders a CMP, that's a comprehensive metabolic panel, and an HbA1c, that's an A1C, adjusts the metformin dosage and schedules a follow up. Okay, coders, go ahead and put your answers in the chat. Good job, good job, good job. Those answers are coming through. All right, I'm going to begin with my inventory. It's down lower left. This is a clinic visit. That's an office visit. It's a new patient visit. The patient has type 2 diabetes mellitus with ankle swelling, and the doctor ordered a comprehensive metabolic panel and an A1C and adjusts the metformin. Coders, can you score this? Who's able to score it? Type in the chat. I want to know. I'll continue. So I know I have to score it. What is the PDR? How do you know, Mrs. J? Because there's no time documented. That is my thought process. If no time documented, you go right into that PDR. So I went ahead and said that this patient has a moderate problem because it's diabetes type 2 with exacerbation. That's my guess. The data, the only 2 tests were ordered. That's low, and the risk is moderate because anytime you're dealing with medication, that is moderate. Prescription drugs, moderate. All right, so what do we do? How do we score it? We throw out the lowest, low, and then we code the next. That will be your score. Now, coders want to tell you anytime you have 2 levels that are the same, that will be your level. Anytime you have matching levels, that will be your level. Now we have a moderate new patient visit. How do we code it? Well, I'm going to look over here, look for the moderate new patient, and 99204 is moderate new patient. 99205 is not, and neither is 0203. 02 is straightforward, 03 is low, 04 is moderate, and 05 is high. And look at this 992013. This is what we studied this. We know that this is an established patient. We know on site. So the answer is C. Now, if you needed more, go ahead, type in the chat. If you watch all of the playbacks, you would already have known what these are because we kind of overkilled with the instruction for this, for these office visits. And if you need more help with scoring, let me know. I want to know. Let me know on the survey. Okay, great job, coders. Look at that. Even your peers are cheering you on. Outstanding. Outstanding. Let's try again. You all with me? This is supposed to be a blitz, so just do what you can, right? Okay, of the following answers, which best describes the encounter? A, 99238, 99306, B, 99238, 99239, D, 99239, and 99305. A 79-year-old male was treated for pneumonia at Green Valley Hospital. On the day of discharge, Dr. Patel completed all hospital discharge management activities, including final examination, discussion with the patient and family, and coordination of medications. The provider documented 35 minutes spent on discharge. Later that day, Dr. Patel admitted the patient to Oakwood Skilled Nursing Facility for continued IV antibiotic therapy and daily monitoring. During the admission, Dr. Patel performed a comprehensive evaluation with moderate MDM. The patient's pneumonia remained active, IV therapy was ongoing, and mild dehydration was noted. Okay, coders, go ahead. Type your answers in the chat. Someone says they can zoom in with their phone to read it. There you go, Barbara Ann. Also, it tells me that you're on your phone. Oh no. So Samantha, you might want to go and head on over to the laptop or your desktop to see if that works, or just try the desktop version, that link. And team, if someone can put the desktop link in the chat, that would be amazing. Good job, Miss Lily May, Miss Rosa, Nashuk. You know what? I don't know what the answer is, but I'm glad you put it in the chat. And some of you might say, you prepped this, you should know the answer. You know what? No, I don't. I won't know it until I see it. Yes. So I don't really remember. Some of you have good memories, not me. All right, so here is my inventory. There was a discharging from the hospital. The time spent was 35 minutes. This patient has pneumonia. This patient was also admitted into the nursing home with a moderate MDM. The patient, it says they have type 2 diabetes. Is this a mistake? I'm thinking it is. Yeah, that's from the last one. It's only these three. Sorry about that. My thought process is, what is the guideline for discharges? What is the guideline for nursing homes? I don't remember, but I'm going to go grab my multiple same day visit practice sheet and see if I can find anything. However, if you have an MCG, that guideline is sitting right there. Sorry about the inventory. It's all jacked up, but here we go. This um, nursing facility visit says, hey, you can only have one E&M code per doctor per day, right? But you can code it along with an SNS. When you have, excuse me, you can code it if it's significant and separate, right? So, but this SNS, it doesn't mean significant and separate. It should, but it doesn't. It means that you got to watch if the doctors are different, and when they're different, watch if they're check to see if they have the same subspecialty and specialty. So that's not applicable here, but it says that right here you can append modifier 25 for those significant and separate encounters. However, readmissions and or discharges can be coded additionally. So that means you can code this nursing visit with a discharge. Let's go ahead and read the discharge. It doesn't really give us any guidance. It just tells us how to code it, but you can code this with a discharge. You can code both the hospital discharge and the nursing visit. That's what I got. So I'm going to get rid of B and D because they're only coding for discharges. How do you know with your bad memory, Mrs. J? Well, I've seen these codes so much, I know them. And if I know them, you young people can do it. And the answer is C. Here's why. Because 99305 is the code for initial nursing facility, right? It's 35 minutes. That's what we have a moderate, and this is a moderate encounter, and that's why 99305, this is initial. This is the first visit for the doctor at the nursing facility. Also, 99306 is wrong because it's a high level of MDM, right? So it's not appropriate. And then these discharge codes over here, I know them by sight. There's only two. So 99238 is the code for hospital inpatient discharge for 30 minutes or less. And 99239, that's the code for more than 30 minutes on the date of the encounter. So 99305 is correct, and so too is 99239. So if you said D, why is that saying C there? You know what? I did review this. Interesting. All right, so the answer is D, not C. What did you all say? Outstanding, outstanding. Okay, coders, can you tell me in the chat if this pace is too fast? Why do a blitz if it's not working? Or we can do this blitz, continue, and you can just watch the playback. If you're gold or platinum, you have access to this playback. Let me know what you're thinking. In the meantime, I'm headed over to number 4. All right. Of the following answers, which best describes the encounter? A, 99215, 95. B, 98001, 95. C, 98009, 95 modifier. And D, 98007. Dr. Pace conducts a 40-minute telemedicine visit with an established patient regarding depression management. He reviews the PHQ-9 results, adjusts the SSRIs, and arranges counseling referral. Okay, coders, look at you all. Look at you. Okay. Miss Frazier says she's good to go. K for Kitchen didn't say nothing, but I think she's good to go. Outstanding. Oh, I know it's fine for you, Miss Rosa. I don't want to leave anyone behind. Okay, go ahead. Put your answers in the chat. Tell me what that asterisk means. Does it mean that that's your final answer? I like it. I like it. It's one cat. Outstanding. Shantae, Nicole. And I'm not saying this is the answer. I like the fact that you took the you took the, how can I say, it's not a risk, but some people just can't bring themselves to put the answer in the chat. And you did it. Outstanding, Nashuk. All right, here we go. This is my inventory. We have Dr. Pace. 40-minute telemedicine visit. This is an established patient. The patient has depression, and these are depression screenings. Now, that SSRI, that's the medication. So, my thought process, use telemedicine codes. That's my thought process. And look at these codes. They're new, right? This 99215, this is an established high office visit. 98001, this is a new low telemedicine visit. 98009, this is a new low telephone visit. And 98007, this is a high telemedicine visit. All right, so we're going to get rid of A, 99215, because it's coding for a high office visit. While in the past, we used to use these before we had better codes. Now we have these telemedicine visit codes, and we will use those. And remember, when you're coding for telemedicine, you must have both audio and visual to use the synchronous, synchronous, synchronous synchronous audio visual visit. Make sure you are coding for the correct. Telemedicine is audio and visual. Telephone is audio. All right, so we're going to get rid of 99215 for the reason I've stated. Also, oh, let's go back. Just want to show you that there is a chart. So if you want to get familiar, how do I use it? The chart is there. Now I continue. Also, we are going to be coding for 40 minutes. Telemedicine, that's audio and visual. So 99201, although it's audio and visual, this is a new patient and our situation isn't established, right? Right. So that's wrong. You got to go. 98009, this is also a new patient, but it's a telephone visit. So that's wrong too. In 98007, this is synchronous audio video visit, and this is an established patient of high MDM. High is 40 minutes. 40 minutes must be met or exceeded. So if you said D, way to go, way to go. And you know what? I'm really giving you props. How many of you coded these codes before? Go ahead, type in the chat. A lot of people, a coder, you all took the plunge, you went ahead and you coded the best of the four. And that's what you got to do when you're taking your exam. All right, let's go ahead and let's try it again. That's right, Mr. Sandeep. They are amazing. Okay, so if I'm talking and you want to read ahead, go ahead. Feel free. Okay, coders, which codes apply? A, 99291, B, 99291, 99292 times 1, C, 99291, 99292 times 2, and D, 99285, 99291, 99292. A hospitalist spends 80 minutes of critical care time stabilizing a patient in respiratory failure following COVID-19 pneumonia in the ED. What say you? Go ahead, type your answers in the chat. These codes are from the evaluation and management section. That's towards the beginning of your manual. Good job. That's what I'm talking about, Nicole. You did it. Good. You all should just pat yourselves on the back. Look at that. These answers are coming through. You all are not afraid. That's what I'm talking about. That's what I'm talking about. Ms. Rosa said page 29 is where E&M begins. Good job, good job, good job. You all are amazing. This is my inventory and thought process. Number one, the hospitalist is in the ED. They spent 80 minutes of critical care with this patient. Patient has respiratory failure, COVID-19, and pneumonia. My thought process, was there a full ED encounter separate from the critical care? Was it? No. The patient, the doctor did what they had to do in the ED, but carried out critical care. So whenever that happens, you code the critical care. You code what the doctor is doing. So 99285, the ED visit is not codable. So we're going to get rid of D. Now we're just going to turn our attention to this chart. I love the chart because it makes it easy. I don't have to think. So I'm going to code 80 minutes of critical care time, and I'm going to look for my 80 minutes, and it falls here, and it tells me code 99291 one time and 99292 one time. And the only one that's doing that is B. So I'm going to get rid of A and C, and the answer is B. That's right. Somebody said this chart is a must for some people, especially when you're taking your exam and you really, really shouldn't rely on your brain unless you need to, right? That chart is there. That chart is your brain. Let's try again, coders. Are you ready? Yes, I've got my MDM chart up here. Let's go. Of the following answers, which best describes the encounter? A, 99212, B, 99213, C, 99214, D, 99215. An established patient is seen in the office for sudden onset, persistent migraines with neurologic disturbances not relieved with current medication. The provider orders an MRI of the brain, prescribes rizatriptan, and refers the patient to nephrology. Okay, coders, what say you? Go ahead, type your answers in the chat. And welcome to our new member, Casual Magic. Way to go, way to go, way to go, everyone getting those answers in the chat. Overwhelmingly, you all have said. And you know what? I'm putting my thought process in. If you have time, put your thought process in. I want to know what you're thinking. All right, this is an established office visit. There are sudden, onset, persistent migraines with neurologic disturbances. No medication relief. That means it's intractable. Whenever you see that word, that means it's not responding to medicine. All right, the tests, only one test. This patient had an MRI of the brain, and the doctor prescribes medication. So my thought process is I don't see any time. What is that PDR, right? What is that problems, data, and risk? Well, my problem, this patient has persistent migraines with one acute problem with systemic symptoms. Anytime it impacts the entire body, that is a systemic system. And you know what? Your nerves are throughout your body. So I gave it a this. Okay, it's under the moderate section. One acute illness with systemic systems. The data, there's only one test ordered, one, right? So it's minimal, right? And just so you know, here's a quickie. If you all want to gem, here it is. For the straightforward, one test. Low, a minimum of two tests. Moderate, three. And then that's all I'm going to give you. I'm going to give you 0 to 1, 2, and 3. Hopefully you got that, right? There you go. All right. So what are you going to do? I'm going to go ahead and score my risk. And the risk is moderate. Why? Because the doctor wrote a prescription for rizatriptan, right? Anytime a prescription is written, it is moderate. So we've got a moderate problem. We've got a minimal data, and we have the risk that's moderate. And didn't I just tell you that if two match, that's your answer? Right? So we're going to throw out the lowest, the minimal, and we're going to code the next lowest. It's moderate. So this is a moderate encounter. And if you're using this AMCI PDR chart, here are the codes here. So if our code falls right here, it's either 99204 if it's a new visit or 99214 for an established visit. We're coding for an established moderate visit. Our answer, 99214. And if you said C, way to go, way to go, way to go. You know what? You all are incredible. You don't need me. You don't need me to do this. You all are rocking. That's what I'm talking about. All right, let's try again. We're on scenario 7. Of the following answers, which best describes the encounter? A, 99255, B, 99222, C, 99285, and D, 99244. An orthopedic surgeon sees a patient in the ED at the request of the ED provider for a consult on a fractured radius. The orthopedist provides definitive treatment and admits the patient with moderate MDM and writes a report back to the ED physician. All right, coders, what say you? Go ahead, type your answers in the chat. Well, I can't tell, Miss Lily Mae, you all are rocking it. Well, some of you are. I know there's about 64 people here, and the ones that are answering are really, really doing well. The others might be laying back, and they might be laying back for a reason. So don't, listen, those that are watching, go ahead. This is no judgment zone. We don't judge at AMCI at all. We don't judge our students at all. We only judge you if you do some stuff you shouldn't be doing, right? Like process of elimination. Don't do that. Please, please, please. All right. And I don't think any of you are doing that. Because if you were, well, you'll see it. You're going to have a hard time. Okay. All right. Here we go. My inventory is orthopedic surgeon consultation. It's in the ED. Patient has a fractured radius. The ortho treated the patient and the orthopedic doctor admitted this patient. All right, my thought process is if the consultation was in the ED, would it be an outpatient consultation? And then follow hospital admission guidelines on the location chart. Okay, so what do? I have an outpatient consultation because it's the ED, right? Patient's not admitted before that consultation. And also, the patient was admitted. What do I do? Okay, first things first, I'm going to label my codes over here. 99222, this is the code for initial hospital. 99244, this is the code for my office consultation. 99255, this is for an inpatient consultation. And 99284, this is the code for an ED visit. Well, on site, I can get rid of this inpatient consultation. Why? Because the patient's consultation took place in the outpatient. Number two, I'm going to consult my multiple same day visit chart, right? And I don't believe these visits can be coded on the same day because they are not significant and separate, right? Yeah. So we've got an inpatient stay, and we can code this consultation if it's significant and separate, and they just are not. So the patient had a consultation in the office, and then they came to the hospital and was admitted. So, is there anything in here that would guide me? Nope, they are not. Um, one is not significant and separate, so I'm going to code the highest ranking, and that inpatient encounter is higher. That initial visit is higher. So I'm going to go ahead and get rid of that ED visit because the ED visit just didn't happen. And I'm going to get rid of this office consultation and I'm going to code B. B is my answer. All right, coders, how you doing? How are you? That's right, Miss Frazier. She said, then it's B. Outstanding job, everyone. All right, I want to see some new people come through. We have 71 people in here. Let's get it. Let's code. You ready for another? Let's go. Of the following answers, which best describes the encounter for the cardiologist? A, 99205, 9922325 modifier. B, 99245, 9923225 modifier. C, 99223. D, 99255, 9922325 modifier. Does anybody recognize any codes? I recognize this one. We just had it. It's good to remember these codes. Dr. Evans, a cardiologist, sees a new patient in her office at the request of the primary care physician, PCP, for evaluation of worsening chest pain and shortness of breath. After reviewing the EKG and performing an exam, Dr. Evans suspects unstable angina and recommends that the patient be sent to the hospital immediately. She documents her findings and plan in the electronic medical record and notifies the PCP. At the hospitalist admits the patient for further workup. Later that same day, Dr. Evans visits the patient in the hospital to review the test results and spends 40 minutes face to face with the patient. Okay, that was a lot of stuff, right? So it's good to inventory because it will help you just neatly see what you need to code for. Go ahead, put your answers in the chat, and you all are answering already? Wow. I would need to think about this. I'd say, okay, let me go ahead and inventory. Even though there's a lot going on, I'm a minimalist. I need to break it down. All right, so in the cardiologist's office, a consultation took place. The three R's were met: a request, rendering of the services, and a report in that EMR took place. So it's a consultation, unequivocally, yes. All right, number two, an office visit. This office consultation was high MDM, right? And then in the hospital, the office visit was 40 minutes. You know what? I don't see the 30 minutes for the oh, uh, I'm sorry. It's high MDM, meaning I scored it. I scored it as high. And then the hospital visit, the time is 40 minutes. So we have the same thing as previous. We have an office consultation and we have this hospital visit. But one is, I think they kind of are the same. And but what is different about this one, the second visit was guided by the guidelines. I'm going to show you. All right, so it says that you have to have the three R's. And it says the outpatient consultation may be reported and the consultant's first hospital visit is coded as a subsequent visit. Now, I want to know why the same guideline is not applicable. I got to look into that. But here is the guideline. This came from consultation. So I need to clarify that. So we can code for these visits. And the reason I am coding for both because both were worked up, right? They're both worked up, and the guideline says, hey, you can code them both. And I'm going to code them both. All right. So, but it says the second visit has to be your subsequent visit. Even if it's the initial visit, you got to code it as a subsequent visit. Pardon me. Also, my PDR, I just want to show you how I arrived at my PDR. This is an acute illness with that poses a threat to life. Anytime it's your heart, it's posing a threat to your life. So I'm going to rank it high MDM. You know what? I think I'm getting ready to backtrack on something. Hang on a second. All right. So this patient has a high MDM, excuse me, high problem, high risk because the patient was admitted. So it's high. And then the level will be high level, right? Yeah. So the office visit will be high. That's how I scored it. Now we know we can code both the outpatient and the inpatient visit. And I'm looking at this again, coders, because I'm about to change my mind in a minute. All right. So in this scenario, the doctor saw the patient, rendered a high MDM, then suspected um, hmm, the guidelines say you can code it, so I'm going to do it. I'm going to code it. The guideline says code it. All right. So 99205, this is your office or outpatient visit. We had a consultation, so we're not going to use that. 99245, this is a high office consultation. 99255, this is inpatient or observation consultation. No, the consultation was in the office. We're not going to code that. 99223, this is inpatient hospital initial, and this is high, and this subsequent inpatient visit, that's high. So I'm going to get rid of the office visit. I'm going to code the consult, the high consult. I'm not going to code the inpatient consult because this is outpatient. I am not going to code the initial hospital because the guideline tells you that if you had a consult and then the patient's admitted, you have to code it as subsequent. You do. So 99245 and 99232 are the answer. And yes, I will go back to 7, but not today. Not today. Watch the playback. I will address it. The guideline says you have to code it, and I got to tell you why it doesn't apply in the previous. So if you said B, way to go, way to go, way to go. Sorry if I confused you. Now we're going to move on. Let's try another. All right, scenario 9. Of the following answers, which best describes the encounter for Dr. Brown? A, 99223, B, 99254, C, 99233, D, 99232. Day 1. The patient is admitted to the hospital by Dr. Green, an internist from ABC Medical Group for evaluation and management of anemia and weight loss. Dr. Green orders initial labs, imaging, and supportive care, and carries out moderate MDM. Day 2. Because of abnormal findings on the bone marrow smear, Dr. Brown, an oncologist from the same group, ABC Medical Group, visits the patient for possible leukemia. Dr. Brown reviews the patient's chart and lab results, performs a focused hematologic evaluation, and recommends a bone marrow biopsy. He documents a moderate MDM. What say you, coders? What say you? Someone said, I like your thought process. She said, it's the same group, but it's a subsequent E&M. Good thought process. But you got to go a little further. Go a little further. Okay, here is what I have. Day 1, Dr. Green. He's the PCP from ABC Group. He admitted this patient. So we're not really coding for him, but we need that for context. Dr. Green carries out this moderate MDM. Now, this is day 2 that we need to code for. Dr. Brown, an oncologist from ABC Group. Dr. Brown carries out a moderate MDM, and we only code for Dr. Brown. Here's my thought process. Is this a consult? No, because Dr. Brown, there is no mention that anyone asked Dr. Brown to come. Dr. Brown came. I don't know how he got his orders. Also, then, are the doctors of the same specialty and or subspecialty? Are they of the same specialty and subspecialty? Yes or no? And that's going to tell you your answer, right? Okay, so it's not an inpatient consultation and it is a visit. Indeed, it is a visit. And you got to pay attention to those specialty and subspecialty. And no, these doctors are not of the same specialty and subspecialty. So if they are not, what do you do? What do you do? Well, you're going to code them both as initial visits. This is their first visit with that patient, right? And remember this little chart. I know this is not, this is the new or established patient chart, but I use this for specialty and subspecialty to just remind me. So definitely use it. All right, so 99233, this is a good code. This is the initial visit code for a high level of MDM, right? It's high. Doesn't Dr. Brown code a moderate? I need a moderate MDM. All right. So 99233, this is the code for a subsequent visit. 99232, this is a code for a subsequent visit. And 99254, this is a consultation. Coders, 99223, even though it's the wrong MDM, it is the best of the four. And when you take your exam, you have to do your job, and your job is to select the best of the four. So 99223 is your answer. Way to go, way to go, way to go. No, I don't make these scenarios. Okay, so it is, we're getting down to the wire. It's almost 12 o'clock. So for those of you that need to go, I understand. Please don't forget to like this up if you do and complete the survey. Also, team, if you can drop the survey link in the chat, that would be amazing. All right. Of the following answers, which best describes the encounter? A, 99215, 9922225 modifier. B, 99223, 99234. C, 99222, 99238, 9921525 modifier. And D, 99234. And coders, you should recognize something, right? You should recognize 99223. We just saw it, right? And we also had 99215 and 99222. A 62-year-old male with chest pain is evaluated by his PCP, who performs a high level of MDM in the office. The provider immediately sends the patient to the hospital for observation status. The same physician admits the patient to observation, performs a battery of diagnostic tests with moderate MDM, and returns the following day, spending 25 minutes discharging the patient with a final diagnosis of GERD and a prescription for omeprazole. Okay, coders, what say you? Go ahead, type your answers in the chat. Thank you, Ms. Mills. Okay, okay, okay. That's what I'm talking about. You all are doing an amazing job. You are. Okay, coders, here's my thought process. Today, the PCP in the office carried out a high MDM. Also, today, that same day, that doctor admits the patient to observation with moderate MDM. The next day, that PCP discharges the patient and spent 25 minutes discharging the patient. And my thought process is, can I code for all of these encounters? Yeah, if it's significant and separate, you probably can. And also, my thought process is this is not an admit and discharge on the same day. So anything that's coding for that is wrong. Is the office visit significant and separate E&M service? And discharges can be coded if on different day than the hospital visit without pause. That's my thought process. All right. So I think if it's significant and separate, that needs to be determined. All right. So is this significant and separate? And I'm going to say yes. Yes, because they both were worked up. Right? So this doctor performed a high level of MDM in the office. And then, but there was no diagnosis, no definitive diagnosis. Patient had chest pain in the office. Then the doctor sent that patient to the hospital where they were placed on observation, but a battery of diagnostic tests were carried out, and that doctor had to work that patient up and carried out moderate MDM. So it is separate. And also, it's separate because he concluded that the patient had GERD. He definitively said, hey, you've got GERD. So these are significant and separate. So we are going to code for that visit. We're going to code for that. We're going to code for the office visit. We're going to code for the inpatient visit. We are going to code for the discharge. And for those of you that didn't know, observation is coded the same as an inpatient visit. We're going to code for all three. So with that said, you can just look and see that C is the answer because it's coding for all three. All right. So we conclude that this is not a same day admit and discharge on the same day. That 99234 is your admission and discharge on the same day. Patient's got to be there for 8 hours or equal to 8 hours or more, and they have to be discharged on that day. Didn't happen. So we're going to get rid of B because it's coding for 99234. Also, D is coding for 99234, and that leaves us with A and B. So we are going to code this 99215 because that high MDM visit, did take place. We also are not going to code for initial hospital visit for high MDM. No, because it's moderate, right? Sorry, my on clicks are off. And we are going to code for the moderate inpatient visit. So we're going to code for 99215, 99222, and we're also going to code for the discharge day, which is a separate day, 99238. Okay. And notice this 25 modifier is placed on the office visit code as per the guidelines. If it's significant and separate E&M service, it needs that modifier 25. So if you said C, not B, C, 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 outstanding, outstanding. C, if you're watching, it's C. Okay, how are you doing, coders? You want to try again? Let's do it. All right, scenario number 11. You all are cooking. All right, of the following answers, which best describes the encounter? A, 99468. 315009402 94760 B 99468 31500944760 C 99468 31500 D 99291 99292 and 31500. A 1 day old newborn is brought to the ED in respiratory distress. The ED physician performs critical care for 75 minutes, includes continuous poxometry, endotracheal intubation, and initiation of mechanical ventilation. The physician also orders IV fluids, temperature regulation, and frequent cardiorespiratory monitoring. Coders, what say you? Go ahead, type your answers in the chat. And if you have time, let me know your thought process. I want to know. Okay, maybe I wore you out, but I don't see anything coming through the chat, but we got to go. This is a blitz. Let's do it. Okay, so we've got a newborn in the ED. 75 minutes of critical care took place. An oximetry took place, endotracheal intubation, mechanical ventilation, and then the doctor orders a few things, right? Orders IV, does temp regulation, temperature regulation twice, and cardiorespiratory monitoring. All right, my thought process is the patient inpatient or outpatient? When you nail that, you can answer this code. You can answer this question more readily. All right. So we know the patients in the ED, they're not inpatient, right? Right. So we're going to go to the outpatient critical care codes for infants. Yes. Anytime an infant is in the ED, it's outpatient, specifically newborn to 29 days. They use these 99291 through 99292. Okay? They're not, first of all, they're not inpatient. And if they were inpatient, you would use the inpatient codes. So right away, we can just go ahead and solve this scenario. Get rid of A, B, C, and D. Excuse me, A, B, C, and D is your answer because this patient is outpatient. And if you wanted to do your due diligence, all right. Whenever you have critical care, there are items bundled into that service. So 94002 is the code for ventilation assist and management. And that took place, right? And anytime these items are in your list, and I like this coding tip because it's right near the codes, right? So if it's in this list, it's bundled. So anything that's on the list is bundled. 94002 bundled. And it's also found at A. Also, 94760, this is the code for non-invasive ear or poxometry. Pox, Poximetry, sorry. Po, pulse oximetry. Sorry about that. All right, so this 94670, it's on this list too. So that means it's bundled into the critical care. And if they are on this list, it's bundled. That means you don't code it. So right off bat, we're going to get rid of A because it's coding for both. And we're going to get rid of B because it's coding for the pulse oximetry. Sorry, that's hard for me to say. And we just have C and D, right? Now, C is wrong because it's coding for inpatient neonatal critical care. It's patients in the ED. And when it's in the ED, we use 99291 and 99292 if applicable. Also, we will code intubation, endotracheal intubation, if it is performed in the outpatient. And I got to tell you, coders, if it's performed in the inpatient, it's bundled. So make sure you pay attention to your bundled codes list. Pay attention. Inpatient and outpatient are not the same. And if you said D, anybody say D? All right, we had some aha moments. That's what I'm talking about. We had those aha moments. But you know what, coders? If you stay true to the guidelines and you pay attention, you're conscious of your location, you could have eliminated something on site. Okay, coders, we got three more to go. You all with me? Let me know. Okay, of the following answers, which best describes the encounter? A, 99386, 9921325 modifier 11102. B, 99386, 11102. C, 99386, 11102 with a 25 modifier. D, 99396. A new 40-year-old patient presents for an initial preventive medicine visit. During the exam, the provider notes an irregular mole on the patient's upper back and performs a focused skin evaluation with low MDM. A shave biopsy is performed to rule out malignancy. BMI is 27 and all vaccines are updated. Okay, coders, what say you? What are you going to code? I know that's right. Good job, good job, good job. All right, so while I'm letting you all put some stuff in the chat. What can you eliminate on site looking at those answers? Whenever I read those answers first, I would have eliminated something on site. Anybody know what they would eliminate on site and why? This is important because this is an aha moment. It's going to really help you. If you don't know, say, I don't know. I don't know, Mrs. J, tell me. I know that's right, Ms. Dolly. Aha moments are the best because that means often you don't forget them. All right, so I'm going to give you a little hint. It's a modifier, coders. What do you use modifier 25 for? What do you use modifier 25 for? I'm going to get rid of C because modifier 25 is on code 11102. Modifier 25 is only for an evaluation and management code. It can only be appended to an evaluation and management code. And that's the difference between modifier 25 and 59. I'm going to let that marinate. Now we can eliminate something else. Somebody said it. Hey, we're going to get rid of 99396 because this is an established patient. Now, I don't know about you. I haven't memorized these codes yet, so I wouldn't be able to do that, but I sure could get rid of that C. All right, so get rid of the established visit because our encounter is for a new initial preventive medicine visit. So we're going to get rid of D, and that leaves A and B. And what is the difference between these two? Okay, so this right here might kind of stump some people, but we are going to use 99386 because this is a new patient for a 40-year-old, right? And here is my inventory. I need this inventory to process this. So we have a new visit. An irregular mole was found. The doctor carries out low MDM and then a shave biopsy took place. All right, coders. So whenever you code for typically surgeries are bundled into the E&M treatment, right? Yeah. And that is where we're going. We are not going to code a new visit. Okay. If a patient went to an encounter for the purpose of that surgery, then you're only going to code the surgery. You're not going to code um, the evaluation and management. You're going to bundle it. However, if the patient went there to assess something and during that assessment a surgery took place, then you can code both. That's significant and separate. But our situation is the patient went there for a preventive medicine visit and they found it during that preventive medicine visit. So it was already found, right? So the next encounter would be for the procedure, right? So the mole was already established. So that next E&M service, the mole had already been established and they knew they were going to excise it. So you would not code for that second visit because it's not significant and separate. You would bundle it into the surgery. We would code for that tangential biopsy, but we would not code that second visit as significant and separate. And if you said B, way to go, way to go, way to go. This was a hard one. This was a hard one. And I typically don't say that, right? But you're not going to have anything like this on your exam. This is way too advanced. But you need to know if the patient came to the encounter for the surgery, the E&M visit gets bundled. Okay. You are quiet. Go ahead. Type your answers in the chat and let's keep going. We've got two more. You are ready? Let's do it. Of the following answers, which codes should be used for the physician's services? A, 99215, 99415, B, 99215, 99417, C, 99215, 99418, and D, 99215, 99358. A 58-year-old established patient was seen in the office on Monday for management of uncontrolled type 2 diabetes and diabetic neuropathy. The patient spent 40 minutes face to face and adjusted the insulin regimen. On Wednesday, he spent 35 minutes discussing the patient regimen with colleagues, reviewing glucose logs and modifying treatment. Ooh, there's a lot of grammar going on in there. I will be changing that. Okay, what is the answer? Go ahead, type your answers in the chat. I tried to give you a little more time. Come on, you can do it. There's only two more. And I'm telling you ahead of time that my answer, the little yellow and black answer, is wrong. Go with the box. Okay. Sorry about that. Okay. So, inventory. We have an established patient. The patient visits on Monday, 45 minutes, and then on Wednesday, additional time was spent on Wednesday. Hmm. My thought process, are these encounters related? The first visit is face to face, and the second visit was non face to face on a different date. And yes, they are related, talking about the same thing. All right. So the doctor worked up the patient for this uncontrolled diabetes. The first visit, the second visit, he even discussed this patient with colleagues, that very problem, and also re reviewed the regimen with those doctors. So, yes, they are related. So if they're related, I'm thinking prolonged services, right? Okay, so let's see. And I am going to select prolonged service with or without. Well, I'm looking at these codes here, 99417 and 418. These codes should only be used for when the prolonged service takes place on the same date of the evaluation and management service. So these can only be used when when the patient is on a particular date of the E&M visit, right? So there was no E&M visit the second time. This doctor, although was carrying out some, well, it was, how can I say it? This was related. This is the prolonged visit. The first one was the visit. The second part is the prolonged. You use this 99417 and 418 when it is on the same day. Okay. the same day as the prolonged visit. So they're not applicable. And I'm going to get rid of 99417 and 418. You got to go because there's a better code. Yeah. Now that leaves me with A. And what's the difference between the two? Well, A is coding this high MDM. How do you know, Mrs. J? Because we've seen this a few times today. And it's also coding 99415. 99415 is the code for prolonged clinical staff. Clinical staff, who's that? Those are RNs, LPNs, etc. All right. So you got to go. And the answer is 99215 and this 99358. This is D, prolonged evaluation and management before and after direct patient care. So before direct patient care and after direct patient care, right? Now this 47 and 48, this is on the day of the direct patient care. All right, how you doing? And don't listen. Don't leave me now. Come on, we can do. We got one more. No, we got one more in a bonus if you want it. All right. So, of the following answers, which best describes the encounter for the nephrologist? A 99366, B 99367, C 99368, and D 99214. A 68-year-old patient with CKD and heart failure participates by phone in a 35-minute medical team conference. The nephrologist, cardiologist, and PCP discuss medication adjustments and coordination of care with the patient actively engaged. Okay, coders, you can do this. Let's go. You can do it. Let's go. Come on. And also, if you have time, let me know your thought process. It helps me help you. Okay, they're starting to come through. They're starting to come through. Come on, coders. You can do it. You can. Take the plunge. Just press your answer. Press send. Press enter. Let's do it. Here is my inventory. This is a CKD patient with heart failure. This patient participates in the medical team conference by phone. A nephrologist, cardiologist, and PCP are in attendance. My thought process, is this a medical team conference? And the answer is yes, because you have to have 3 people from different disciplines. So yes. And then the next thing is this face-to-face or not? Is this face-to-face or not? And coders, we can just go ahead and get rid of 99214 because this is coding for an E&M visit, not a medical team conference. It's a distraction. And is this face-to-face or not? No, the patient's on the phone. The patient is on the phone. It is not face to face, right? So we're going to get rid of the face to face code, which is 99366, right? Medical team conference, multi interdisciplinary team, get rid of it. And that leaves us with B and C. And what's the difference between B and C? Well, 99367 is the code for physicians, and 99368, this is the code for non-physician qualified healthcare professionals. Well, who is that? That might be a physician's assistant, that might be your nurse practitioner, it could be your speech pathologist, it could be your physical therapist. None of them were there. We're coding for the nephrologist. That indeed is a physician. So 99367 is our answer. And if you said B, way to go, way to go, way to go. And remember, coders, if the patient is on the phone, they are not face to face. Now, if they said AV, right? Telemedicine, and they could see the patient, That's different. Just saying. I have one more if you want it. If you want it. All right. Of the following answers, which best describes the encounter for the cardiologist? A. 99360, B. 99358, C. 99291, and D. 99464. A cardiologist is requested by the ED to remain immediately available for a potential pacemaker insertion during a high-risk cardiac procedure. The cardiologist provides standby services for 1 hour, but is not called upon to perform the procedure. Okay. I see you, DC Kicks. Where you been? Good job, good job, good job. Go ahead and put that final answer in the chat. And if you want to go ahead and tell me your thought process, and don't assume that it is basic. You saw mine. Is this inpatient or outpatient? That's important that you establish that. Okay, so here's my inventory. The cardiologist was requested to remain available. That means stand by. And that cardiologist stood by for 1 hour. And that cardiologist was not called to perform. So my thought process, the cardiologist stood by and did not have to do anything. So I'm going to get rid of 99291. This is for critical care. Critical care means you're actively engaged with that patient. No, that did not happen. We're also going to get rid of 99358. This is the code for prolonged E&M. That didn't happen. That doesn't fit the description of prolonged service, right? Because no E&M code, no care took place before or after this encounter. Also, we're going to get rid of 99464. This is a code for attendance at delivery. This is a pediatrician code, right? Going to get rid of that. And our answer is A. And coders, if you got that correct, outstanding. I was prepared to go ahead and review the AAPC, the software, the E&M software, and I'm just going to tell you that this E&M software is on their website. Go to aapc.com and you click on the software and services, click on E&M. And this was the scenario that we did earlier, scenario 6. And I just plugged it in to the calculator. And as you can see, they want you to put in the date of service and the type of service and these 3 elements. And then you press save. So I put the date of service, outpatient, established patient, and I press save. Do you see how important it is for you to nail the location? It's not going to do it for you. You got to tell them what you're coding for. Also, you have it takes the information that you plug in for your PDR. So our problem for this scenario was 1 acute illness with systemic system. I clicked on that. Then we took the data. There's only 1 unique test, and it totaled it 1. Now the risk, you can select the risk that you that's applicable, and we've said that the risk was decision regarding was it decision regarding surgery? Yep. Is it? Is it decision regarding surgery? I don't think so. But anyway, this is our scenario, and it did come out to be the same. So make friends with that tool, because that is the tool that you're going to use when you take your exam. If you're taking the CPC exam, you don't really even have to use it, but it's there for you. You don't have to. But if you need the tool to score for you, there you go. But you keep doing this. You don't need that tool. That might be a time waster, huh? All right, so just want to review what we talked about. We talked about in the entire series of this evaluation and management, we learned about new and established patients and initial versus subsequent visits. We talked about multiple visits when you have one encounter. We talked about shared and split visits and separate procedures. We also talked about consultations. We also reviewed critical care, prolonged service, preventive medicine, and discharges. And then we talked about medical team conferences, care management, care plan oversight, cognitive assessment and care plans, psychiatric collaborative management services, transitional care management, advanced care management, and behavioral health integration. And we finished today with application to practice. We did the evaluation and management blitz, the AMCI blitz, and we featured the AAPC E&M calculator. And I am very happy to do these sessions again, little small sessions, maybe if you just want to score, whatever, but you have to let me know. Now we are finished with the evaluation and management series. Go ahead, make sure that you look out for the playback. All 7 parts are in your course if you are an MCDC student. If you are a gold, you can watch all 7 parts on YouTube and they will be available tomorrow. Okay, just want to let you know what we're doing next week. What are we doing? I'm going to guide you. Yes. So I'll be sending out more information about guiding you through. We're going to guide through the CPT section. Yes, we're going to start with it, integumentary. Yeah, no, it's not straight instruction. I'm just going to be giving you some tips. I'm going to hold you accountable. I'm going to be accessible for your questions. So stay tuned. Okay, coders, thank you so much. And please don't forget the survey. Team, if you can put that survey in the chat, please and thank you. And I just want to let you know that we are pressed for time and I have gone well over. So that is why I'm speaking very quickly. But just know I'm going to address that possible conflict. Okay? Yeah, I'm going to address it in the playback. So no worries. Okay. So way to go, coders. And I want to thank my team. Thank you, Ms. Mills. Thank you, Ms. Dolly, Mr. Sandeep. Thank you for showing up every week. And thank you, coders. And if I could thank you all, I would. But I'm going to try. DC Kicks, Ms. Leslie, K for Kitchen, Say Barla. Very good. I like your elimination. Okay, Britters. Let's see. Jalicia. Vina D, Lily May, Ya, he Yachts, sorry, Helen's, Barbara Ann. Okay, I can keep going, but I will have to keep scrolling up. Okay, so I just want to thank you and have an awesome rest of your day.